Everyone, and thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Kathy Riley, the Associate Director of Programs at CSCLA, and I'm really honored to welcome you to this week's webinar titled Improving the Brain Tumor Surgical Experience for Patients and Families. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer. And that includes patients and caregivers and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. And if you would like to learn more about our services or watch past webinars that we've hosted, you can visit our website at cancersupportla.org. And before I introduce today's speaker, you'll notice that your video and microphone are automatically disabled for this webinar. We encourage you, however, to enter questions into that Q&A feature found at the bottom of the Zoom window at any time. And questions will be answered by our presenter at the end of the presentation. We might not be able to get to all your questions today, but we'll get to as many as possible. Dr. Kunal Patel graduated at the top of his class with Alpha Omega Alpha honors at Weill-Cornell Medical College in New York and completed a one-year research Howard Hughes Medical Institute fellowship at the University of California, San Diego. Dr. Patel completed his residency training at the University of California, Los Angeles with an enfolded fellowship in neurosurgical oncology. Dr. Patel is an author on over 75 medical research publications, has had his research funded by the Broad Center for Regenerative Medicine, UCLA Health Jonsson Comprehensive Cancer Center, Burroughs Wellcome Fund, Howard Hughes Medical Institute, and the American Brain Tumor Association. He has won research awards through the American Association of Neurological Surgeons, Congress of Neurological Surgeons, and North American Skull Base Society. And it gives me the greatest pleasure to welcome today's speaker, Dr. Patel. Dr. Patel, welcome.
Thank you very much. Thank you all. I'm really, really honored to be asked to speak a little bit about my views on surgery for brain tumors and some of the research and new advances that we have come about both here at UCLA and kind of just in general over the last decade. Thank you for that wonderful introduction. I am a neurosurgeon and neurosurgeon scientist here at UCLA. What that means is I do surgery half the time for patients who have both malignant and benign brain tumors. And then the other half of the time, I work in the lab to try to find a treatment or at least work towards a cure for some of our malignant brain tumors or brain cancer. And so my life basically revolves around this. I love it. And one of the best things about this job is the connection I have with other people. It's really a deep connection, figuring out that you do have a brain tumor, having the surgery together, dealing with the post-operative recovery together, which is not easy, And then the long-term follow-up. Sometimes it's amazing and people do great for many, many, many years, and that makes me happy. But it also, I think, is important to be able to be there for patients who maybe doesn't go so well with for. And I think it's important to try to guide through that process as well, because this is still a disease that we need more support on, we need more research on, and we need to have better treatments for. So the way I'm going to structure this talk is really first talking to you guys a little bit about what it, I guess, what it would be like to have a brain tumor today. What does it mean like, what does it mean for you? What is the experience? And then to move forward with some of the advances, specifically the ones that I focus on in terms of treatment for brain tumors, and then patient experience for patients undergoing surgery for brain tumors. So thank you so much for listening. Please put any and all questions in the chat because I'm going to finish with enough time to answer as many questions as you have. Okay. So when a patient comes to me and is first diagnosed with a brain lesion, many times the radiologists, if you have a headache and you go get an MRI scan, we'll call it a lesion, and then they'll come to me. And I think the most important four things that I kind of go through whenever I meet a patient, whether it's over the phone, whether it's in my clinic, whether it's in the hospital itself, is you have to know what you have, why you have it, what does it mean for you, and then what are your options, okay? And so this really differs for patients with different types of pathologies and different types of brain tumors. When you're asking a physician or really trying to understand your condition in terms of brain tumor, the way I think about it is there are two major categories of brain tumor. One is cancer, brain cancer. It's also called a high-grade tumor, which is the same thing as a malignant tumor. So that's like one category, and people throw around those words a lot, but for our field, they mean the same thing. The treatments are the same, and I'll get to that in a second. And then the second type of brain tumor people get, which is also extremely common, is a benign brain tumor. And now people in this chat may have had diagnosis of meningioma, diagnosis of glioma, glioblastoma. So there's a variety of different types of brain tumors, but I think one thing that you should definitely try to either talk to your doctor about or really understand upfront is this something that is like a brain cancer, or is this something that's like a benign tumor? The next question you really need to know is why you have it. And this is the one, usually the shortest conversation that I have with patients, because we really don't know a lot of risk factors for brain tumors. We know there is not a risk factor for cell phones and microwaves and flying a lot and most jobs, given like the restrictions on most jobs with radiation. We do know there are some very, very rare brain tumor genetic diseases, but those are often caught early, and we have really good testing for that. The vast majority, so greater than 90% of patients that I see, I usually say, I don't know why you have a brain tumor, other than just poor luck. What does it mean for you? So brain tumors are special than all other types of tumors. I mean, I have a lump on my elbow, and doctors say just live with it. I guess maybe if you want to look good, you could get it out, but otherwise it doesn't matter. Some people, you can have really large lesions in your belly, in your lungs, in your back, and you may not notice. The brain is a really special place. And the reason why the brain is a really special place is because there is no room for any strangers in your head. Let me explain what that means. Your brain is just a little bit smaller than your skull, and your skull cannot grow. And so if there's anything inside your skull, inside your brain, or on the surface of your brain or around your brain that's taking up space, you're going to feel it, and you're going to feel it very early. Most commonly, we notice that people feel or have symptoms related to their brain tumor by the time it's about 2, maybe even 3 centimeters. Some people earlier, obviously, some people later, obviously, but this is just in general what we've noticed. And like the real reason for this is because of the fact that there's no more space in your skull. We call this, and the radiologists, if you look at one of their reports, call it mass effect. But really what that means is because there's no space for your brain to expand, it's just being pushed by whatever lesion, whatever tumor, whether it's malignant, whether it's benign. And that's what causes symptoms. And that's why people come to me with even really small lesions, because brain tumors are very symptomatic. Now, some of you guys will have, no symptoms, and then all of a sudden you say, "Oh my God, they found like a 5 centimeter tumor." It can happen, and it all relates to where the tumor is in your brain. You may have heard, you may have read that we don't use 100% of our brain. And while I don't think that's 100% true, we use everything. Certain things are more important than others. You're going to notice if you can't move your hand, right? But are you going to notice advanced mathematical abilities or a loss in that? Or are you going to just say, hey, I haven't done math in a long time, or I'm getting older? I mean, I'm a brain tumor surgeon. I still literally do not do math. And so that part of your brain, which you may find in the left superior parietal lobule, may be missed if you have a lesion there, because you're not really using those skills every single day. The location of the brain tumor will define how dangerous the surgery is, your symptoms, and is a really important kind of next piece of information you need, because that helps me decide a lot of things. 1, do you need surgery? 2, how dangerous is surgery? 3, how aggressive can I be in surgery? And 4, how is your post-operative recovery going to be? And so knowing what type of tumor you have and where your tumor is, I would say that's question 1, and that's question 2. And then the last thing, what are we going to do about it? Okay. So what are we going to do about it for brain tumors really goes down to 3 options. 1 is observation, 1 is radiation, and 1 is surgery. And I'm going to talk a lot more about surgery coming up, but that is kind of the framework of how we treat these types of lesions for upfront therapy. The reason observation is always discussed and it's always important is because brain surgery is risky. If it was no risk, then yeah, we would be taking out everything left and right. It's not a comfortable experience, and there is risk. Observation is really important in lesions that are not causing you significant symptoms, or symptoms that you can tolerate, in tumors that are not going to be a threat to your life down the line. The second option, radiation, this is something you might discuss with a type of doctor called a radiation oncologist, is used for kind of a couple situations in my experience. 1, tumors that have like a little elevated risk relative to the general average brain tumor. That again is based off of location. The second category is, do you not want surgery? Can you not tolerate surgery? As we age, everyone has other things going on. Some people and some bodies are more apt to tolerate a big surgery like a brain tumor surgery than others. And I think that that's one of the main reasons we have radiosurgery in our arsenal, and the advances in doing this type of procedure. It's way different than it was like when I was in medical school, where people were really getting high doses of radiation to the whole brain and they were not the same afterwards. Now we have something called stereotactic radiosurgery. It's a very, very fancy name for a very, very simple concept, where we just take all the radiation and we focus it in on one spot. And the advent of that and the development and use of that, the ability to target the radiation, has really, really opened up doors for brain tumors, because the side effects for that are much, much, much less than the traditional, just radiating the whole brain. And then the last, my favorite option, is surgery. Obviously, surgery is really, really good at treating most brain tumors and is the primary treatment for most brain tumors. And so if you're diagnosed with this is definitely something you need to discuss with the neurosurgeon. Having that appointment and really finding someone who you can listen to, who listens to you and gives you kind of the whole story with how the surgery is the most important thing. It's your decision. I mean, it's 2024. You're not just going to uh, come into the office and then be whisked away without any really discussion about what is going to happen to you. And so understanding the benefits, understanding the alternatives, understanding the risks is definitely imperative in your discussion about surgery, if that's something that you're going to do. This is the framework for how I and most neurosurgeons think about when patients come in with brain tumors. And one of the things that I focus on is improving this experience. And the experience really goes from preoperative, that means before surgery. There's actually a lot that we do that I'm going to go through. The operation itself, and then the postoperative recovery. I don't think of the relationship that I have with a patient who I eventually carry out brain surgery on as like the surgery itself. That is the easiest and the quickest part of the relationship. The hardest part of the relationship is one, making the right decision for each individual patient. And that is the preoperative discussion. So let's start with that. So before you undergo surgery for a brain tumor, it's really understanding what do you want to have surgery? And what do I need to have the safest, best quality surgery possible? These things include making sure you yourself are ready both physically and mentally. Unfortunately, we don't have mental um, preoperative clearance. Okay, we have medical clearance. They're going to check your heart. They're going to check your lungs, but it's really up to you. And what I've tried to implement in my practice is a way to make sure that you and your family or your support system or whoever it is ready for the mental stress of going through this process. Maybe one day we will have kind of a more systematic approach to this. But right now, it's really about the conversation with you, the conversation with me or your neurosurgeon, and the conversation with your support system. And then there's the sciencey stuff, which I'm going to show you in a second, which is the magnetic resonance imaging or MRIs. So MRIs, this is a magnet-based, so not radiation-based approach for imaging brain tumors. And this is what we do. Like this is the standard of care across the whole world. At UCLA, we do some advanced MRI, and that's one of the things that I have dedicated my research on. I will show you that in a second, but um, uh, magnetic resonance imaging or MRI is what we use to diagnose brain tumors, to plan out our treatment plan, and then to follow up brain tumors. So this experience of getting an MRI, which I have gotten an MRI myself, is not comfortable. Is something that you're going to have to understand is imperative for appropriate treatment of brain tumors. And the operation itself, I'll show you some pictures, but I didn't want to get too into it, and they're very casual pictures. They're nothing that hopefully will be of issue at all. The operation itself is, again, the easiest thing for you, and honestly, some of the easiest parts for me too. They're very standardized, and our surgeries are getting better and better and better. And I'll show you a little bit of data on how much we've improved just since I have entered the field, which is almost 8 years ago. But if you take away the last, if you kind of evaluate the last decade, I'll show you some of the ways that we have made surgery safer, more efficient, and then actually better for the outcomes itself, including awake brain surgery, which is one of the things that I specialize in. And then lastly, the postoperative recovery. This is the thing that everyone always wants to know, like, what is the recovery from brain surgery? Number one, the answer is it varies. But in general, what I tell patients is the rule of twos. And so I say about 2 days in the hospital, 2 weeks with either rehab-based care or care where your support system is supporting you at home. And then 2 months, most people are back to work, but mostly, I always say it's mostly the people who want to be back to work are back to work, and people who don't want to be back to work are not back to work. So I'm not sure how much of that is the surgery, but in general, most people are back to work by 2 months. And then it's that 2 year part, which seems a little crazy, but really I've noticed it's the 2 year mark where people are saying, oh yeah, I forgot about that, or yeah, that seems more like a memory to me. There are little things that really persist after a big surgery like this, excuse me, that take a long time to really become your new normal. So let's start. So I want to transition from kind of this is just a basic framework for how to think about the rest of this conversation. And I want to talk to you about what I do specifically at UCLA and some of the advances that we have as a group have done to move the preoperative, the operative, and the postoperative patient experience forward. So preoperatively, so this is an MRI. This is an MRI of brain cancer, also called glioblastoma.
Dr. Patel, we are not seeing your slides. Are you
Oh,
sharing slides?
yes. Here, I'm going to just restart them, please.
Okay,
Thank you for letting me know. Let me know if you see them now.
perfect. We do.
Perfect.
Thank you.
Good. Good. So perfect timing because this is the first image. So the preoperative work, so we're starting with just what do we do before surgery that's kind of new and different. Um, this is an MRI. This is what we see in terms of an initial diagnosis of brain cancer or glioblastoma. You'll see that this gray stuff is your brain, and this white lesion right here is what a typical brain tumor, brain cancer looks like. It's white, and when I say it's white, it means it's taking up the contrast that you're given during the MRI. Brain tumors, they basically leak out this contrast, and so you can see it on the magnetic resonance imaging or MRI versus your normal brain doesn't leak out because the way your brain is built is to protect your brain from any weird substances that might be in your blood. And so the rest of your brain really, it doesn't really leak out into the brain. We take advantage of that to see lesions like this. What I specialize in, and one of the things that I like to do for surgery is, and these are fancy slides, but I'll explain them, something called a functional MRI. So what is a functional MRI? It is an MRI where you participate during the MRI. So you're getting an MRI scan and you're doing different activities. And so if I think the tumor is in an area where it's involved in the strength, let's say, of your right foot, I can have you move around your right foot during the MRI to get a sense of what is the relationship between what I need to remove and what is controlling your right foot. So you could see here on the right picture, these red spots are areas that are active when people do a certain activity. I think this person was reading a book. And when you're reading a book, look at how many things are active. You can see that there's a sidedness to it. This side, which in medical imaging is the left side, is brighter and more yellow, and there's just bigger areas of activation than the right side. And that is very common in most people. The left side is the area that controls things like language. And then what I do with this data is there's this long process, but basically we take this data and we can make it into objects that we could use in surgery. So this is, while you're asleep in surgery, this is what I'm seeing. It is in the top left, it's a reconstruction of the patient's brain. And then that like instrument is literally what I'm using in the surgery. So it tells me exactly where I am. And then prior to surgery, I usually color coordinate different things. So like here you can see this is a brain that has a lesion that is colored in like yellow. And the important fibers are colored in like this purple and blue, where the purple is the sensory fibers and the blue are the motor fibers of the brain. And what you can see is I can kind of work around those important fibers. You'll see in the bottom right corner picture, it's right on the surface of the tumor, the important fibers, and use that to remove the tumor without damaging anything that's important. So again, this is kind of one of the techniques we use here to um, uh, improve surgery for patients who have um, uh, brain tumors near important areas of their brain. The next thing that I do, and this is a citation from a paper that I published in just recently in 2020, in this January actually, and this is another use of the technique called magnetic resonance imaging, or MRI. This is a pH. pH, if you may remember from high school class or something like that, is like acid and base. It's a measure for how acidic something is. And so we have been using MRIs that are associated with pH detection to detect more of the tumor or spreading areas of the tumor to improve our surgical resections. And so you can see again, there's a variety of ways for us to use either activity and functional MRI, like we talked about before, or special characteristics of the tumor, like acid, base, or acidity of the tumor, to help guide us in surgery in real time to improve surgery, to improve like the amount of tumor that's resected and how safe it is. Intraoperatively, you're going to see a few pictures here. I just wanted to show you like what do I see in surgery and why do these MRIs and things help me remove brain tumors? This is the example of the most common type of non-cancerous brain tumor, which is called a meningioma. You can see here, if you can see my mouse, please let me know if you don't see the mouse. This lumpy thing here is the tumor itself. Okay, and then this is the brain. Okay, these types of tumors do not invade the brain. So you can see right here, I'm making a dissection pattern between the brain and the tumor, and it's very obvious. This is the easiest type of tumor, I think, to remove because, I'm sure you're looking at it and you can even see the difference between the normal brain and the obviously abnormal tumor. Then there's kind of a medium level, I would say, difficulty. This is called a brain metastasis. This is what it looks like if you have a metastatic lesion, whether it's your lung or your breast cancer, that goes to the brain. Here, again, you can see the normal brain all around it, but you can see that this is kind of looks like the normal brain. It's just redder, okay? Including it shares the same blood vessels. You see this one right here is coming from the brain, and then the brain tumor is also using it. This increases the level of complexity because this is actually a tumor that's inside the brain. And so here there is no way to separate it from the brain because it's inside the brain. This makes it harder because it's a harder recovery because you have to basically disrupt normal brain fibers. And then here's I would say, most difficult type of brain tumor to resect, which is called a glioma, or glioblastoma is another name that you may have heard. And you can see here that you can see here that the brain tumor itself looks just like the brain. If I told you the cut I made here is basically the border of the tumor in the brain, hard to tell, okay? And it really takes advanced training and many years to really focus on tumors like this. This is why MRIs and special new types of MRIs that can help identify the borders are super important and are very helpful for these types of surgeries. So, improving the patient experience in terms of new research ideas and implementations here at UCLA. So the first is preoperative, before you come to surgery. One of the biggest things that I care about is equity for patients in our Los Angeles or greater Los Angeles area for finding a neurosurgeon on time, getting to surgery on time, and having all the information prior to surgery. I have worked on this pretty extensively over the years, and this is just data from an actual active study that we have on access to care for brain tumors. What I did was I looked at all the patients that were operated on at UCLA over the last, I think it was 8 years since we, I think, went to the EMR and had appropriate data in the electronic medical record. And I looked at all types of brain tumors and in addition to spine tumors. And what we looked at was, are there differences based on who you are to if you have delays to care and if you have worse outcomes, I would say. We looked at your race, your gender, patient's socioeconomic status, insurance status. And then there's kind of a fancy statistical model that you can implement to try to identify which one of those factors is actually the strongest factor in identifying issues to access to care. And we found a lot of interesting findings. And so the timing to get into surgery, the timing to see a neurosurgeon, the timing after surgery, if you needed chemotherapy, to go get chemotherapy, was delayed based on your racial identity and or your socioeconomic identity. Why this is a new kind of active effort for the next kind of stage of this, and we're doing patient interviews to try to figure out why are there differences here. In addition to that, we look to see, are there, rather than just access to care, are there differences in outcomes itself? Like, are you having more complications? Are you having worse surgery? Or are you not like surviving your tumor long enough if you have certain racial or socioeconomic identities? And we did actually not find anything there. So our thoughts are, the problem here is getting into our hospitals, seeing our surgeons, seeing our doctors in a timely manner, rather than once you're in the system, having issues within the system. So we're trying to figure out how to improve this by doing patient interviews, which is an open study now. And some of the things that we are planning to implement in the future or already have implemented are the following. One is basically immediate appointments. So is there a way, if you get a call from your primary care doctor saying you have a brain tumor, that same day you can see one of us, whether it doesn't mean you have to schedule surgery, but just to have someone who is a professional and an expert in brain tumors speak to you that day you get that big news. Number two, we've hired and implemented someone called a nurse navigator here at UCLA. She is amazing. And what she does is a really good, I think, model for the future. And what that is you speak with the doctor and then you speak with her. And you'll be surprised every time you speak to a doctor, and I felt like this as a patient myself, you forget the questions you were going to ask. You forget what you talked about. And so what we use is a nurse navigator to try to decrease what we see here in this data, which is delays to access to care. And the last thing we do is try to help get you the answers before you even see the doctors. So if you see a primary care doctor and you're waiting to see me, what we're trying to do is have a system where we can discuss your case with every neurosurgeon, neuro-oncologist, radiation oncologist, the nurse navigators there at this thing called the Brain Tumor Conference or Brain Tumor Board. And what we do is get a sense of what is the right treatment. So even before you see the doctor, you don't have to then say, okay, well, we'll see you next week and we'll have a plan. You get the plan right then and there. So this is something that I think traditionally in medicine we have not focused on: immediate care, navigating care, equality in care. But this is something I think as we have more and more new generation of doctors, this is something that we care about, and I specifically really care about. The second thing regarding patient experience is, as you know, we have an opioid crisis here in America. And I have studied the idea of decreasing opioid use, but basically preventing pain after brain surgery. And so these are two papers that now seems actually a few years ago, in 2020 and 2021, that I published studying alternative medications rather than opioids that are not in that class and not addictive, to help patients get through surgery with minimal pain. And that includes basically medications that are used for like migraines, medications that are anti-inflammatory medications, and as specific procedures that I can actually do in the operating room around the surgery to decrease opioid use. What we notice is if you do this, patients don't need as many strong opioid type medications. And in fact, many of them don't actually even leave with them. The reason why you can get away with this with brain surgery specifically is because the brain itself has no pain fibers. And because the brain has no pain fibers, you feel no pain from that. You feel pain only from the muscle and the skin that's cut. So it's not like an orthopedic surgery that hurts a lot, a lot, a lot. And because of that, we're trying to eliminate actually the use of opioids and really just get you in and out without the use of those types of medications. So I'm seeing the questions line up. So I want to see if we're at 12:45, we can start switching to questions. I just wanted to conclude with the idea of as you know, basically as neurosurgeons continue to come out of training and get ready to take the mantle as the next generation of surgeons, which I definitely fall into that category, only being 8 years out of the school. The treatment of brain tumors, and specifically with MRIs, minimally invasive techniques, are really important for the advances of clinical care. And then things that I think are underrepresented in our research literature, which are access to care, equality, decreasing like the actual inpatient experience. So not staying in the hospital as long and not being on opioid medications. And then having the support, whether it's our nurse navigator, mental health, or just, all the other stuff that we need after brain surgery. That support period is stuff that we have really started to work on and have a lot more, we have a lot more to do, but hopefully I showed you a little bit of the directions we're going there. I want to, before we get to questions, just acknowledge everyone in our community, because just to provide this, I just gave you some tidbits of data there and some papers that you can go ahead and take a look at. But this involves my lab, as well as a variety of labs who work here at UCLA, some of which are neurosurgeons, some of which are PhDs who help really move the technology forward because they're not doing surgery, all day long. You can, as well as basically all the other brain tumor surgeons in the Department of Neurosurgery at UCLA who have paved the way, provided me support, and basically provide excellent, excellent care for all of our patients. And then, as you heard, I'm funded by several places to actually continue this research. And so I just like to acknowledge them for the support, which, a lot of their support comes from donations from people and families with brain tumors. And so I really acknowledge all that make this research possible. I'm gonna just start, unless you think that we want to pause for a second. I was just gonna transition right into the questions because I see the Q&A popping up. I'm just gonna go down the list, okay? And then please add more as you guys think of more questions, and we can kind of go from there. So is there a replacement for gadolinium as contrast? So there are alternative ways to identify brain tumors that are not associated with gadolinium. The standard of care, which means the best thing in my mind, or what most people do, is gadolinium contrast. But you can get a CT with contrast, which can identify tumors. I've done that in people who have had, I'm so sorry. Who have had problems with gadolinium contrast in the past, whether it's allergic reactions or sometimes people with kidney issues cannot have gadolinium contrast. But I would say that is what I would prefer, unless it's a strong contraindication in which you can try to get away with. There's something called Gadavist, which is not quite gadolinium, and then you can try to get away with some of the CT-based contrast dyes. The next question is, if parts of the tumor envelop a sensory part of the brain, you need to leave some of the tumor, right? However, the metastasis will grow. So this is really a great, great question. We use the term eloquent brain, okay? It's an old term, but what it means is part of the brain that we think has important function. And that itself is really a question that is open-ended in my mind. What is important? Is your strength important? Right? Would you want to be paralyzed? Would you want your hand to be paralyzed? Is the sensation, would you want to be numb for the rest of your life? Would you want to be able to talk and communicate with people? Would you want to be able to read? Obviously, everyone wants to do all these things, but if you are weighing that versus cancer, what would your answer be? I don't know the answer to this. I'm still working on it myself. I've never been put in this position myself, but I'm learning from my patients and trying to figure out what is the best outcome. Because if you want to be aggressive in terms of brain surgery, having a small neurologic deficit may be the way to go. Other times you might say, well, no, if I wasn't able to talk, that would absolutely ruin my quality of life. I would never want an aggressive resection in that area. We've done a few studies on this, and we've noticed that there are some neurologic deficits, such as language, which really, really, really decrease a patient's quality of life, while other deficits, like being able to, see in the corner of your peripheral field, that don't really decrease patients' quality of life. And so this is a discussion with your surgeon. And specifically, that's why getting the functional MRI is important, and really understanding the relationship between the important parts of your brain, like in this question, the sensory part of your brain, and the tumor. So it's more complicated than just you have to leave it. It's a conversation. And that's how I take care of my patients. Medical recommendation for two meningiomas. One is 0.9 and one is 1.0 centimeters. Not sure about the locations. Obviously I cannot give direct medical advice through this conference. I'll talk a little bit about meningiomas. Meningiomas are typically benign, so non-cancerous types of brain tumors. And what I usually do is, like I said, the two things you need to know about your diagnosis is it benign or malignant? So meningioma are usually benign. And the location. The location matters very significantly because of what I discussed before. If it's in a location that's next to something that's going to cause you deficits, then I would tell you, I would say, hey, if this continues to grow, you're going to experience X, Y, and Z. Other parts of the brain, I could say it could grow for 20 years and you're probably not going to experience anything. So I don't have a perfect answer for this specific question, but what I do have is guidance saying, hey, location, location, location. All right, what can we do if we can't have an MRI to check to see if there's brain metastasis because you have a tissue expander, of course, waiting on radiation, breast cancer, blah, blah. So if you cannot get an MRI because you have a contraindication for MRI, and I've seen it all. You can have metal, like if you had a back surgery back in the day, we were using metal instead of titanium. Tissue expander is a great example. Some people have just scrap metal from injuries and different types of activities that they had when they were younger. There are alternatives. The two alternatives that you can have, again, is a CT with contrast, which can at least give you a sense of if there's anything there. And number two is a PET scan. PET scans are great for identifying lesions, specifically cancerous lesions, all across the body. And oncologists typically use this thing called a PET scan to identify lesions, especially when you can't get an MRI. Have there been any advances in extending the lives of GBM patients? So I would say the biggest way to think about this is, in general, yes. When I graduated medical school, we used to tell people you were going to pass away 1 year from your diagnosis. And that's how I was taught in the books. Now, at high level specialty care centers here are the reasons why people do better. One, better surgeries. So that means more aggressive resections and safer resections. Two, good clinical trials, such as immunotherapy. And then three, early diagnosis and good postoperative care. These are the things I talked about, like having a nurse navigator walk you through the postoperative care, making sure you get chemotherapy on time, making sure you get radiation on time, making sure if you qualify for a trial, you get into the trial. These are the advances that we have noticed have extended the lives of GBM patients. We have GBM patients, and again, these are just some of them, not all of them, who are around for years. And we don't know exactly why, but there's something that we're doing that's improving the overall outcome. It's not a curable disease, but from when I graduated medical school to what I say in clinic now, it's a significant difference. And I look to try to continue to move that difference in the positive direction. Is there a brain map that explains the consequences of brain tumors? Yes, there actually is. Actually, the American Brain Tumor Association has a really good brain map that they have in there. I think it's like a packet called Understanding Brain Tumors or Understanding, I think Understanding Brain Tumors. On the first couple pages, there's actually a map of the brain, and it's actually pretty good. I agree with it. And it's easy to read for someone who is not a medical professional. And it basically will show a picture of the brain and tell you where everything is. And I think it's pretty good. In general, higher level function stuff is very difficult to pinpoint. We don't really, really, really know exactly where everything is. And so you are not going to really understand what it's going to feel like to have surgery in those areas until you have it. There are major areas that are always the same in like every single human, and it's in the same locations, and they're very easy to predict. And those are the areas that we typically use to guide our surgery. We know where vision is. We know where strength is. We know where sensation is, at least basic sensation, like, oh, I can feel this on my hand or I can feel this on my knee. We know where language is. And those are kind of the major things that we worry about and work with for brain surgery. There's so much work to be done because, as you know, we're way more than that. The thing is, it's very complicated and actually really hard to study, where the specific areas, if brain tumors are involved in these areas, what the postoperative symptoms are going to be. Because sometimes, because we have two hemispheres or two sides to our brain, if you mess up one side or basically the tumor is involved in one side, your other side can compensate. With a CT with contrast, how thin should slices be when looking for brain metastases? So if you're just looking if it's baseline, I mean, you can do 2 to 3 millimeter cuts. This is called a thin cut CT. This is what I use for surgical planning. And we call it, the sequence is called an MP RAGE. So letter M as in mom, P, and then rage, like angry, RAGE. This is the standard type of MRI sequence. And for the CT, it's just a thin cut CT, which everyone has kind of the same protocol. And I think it's about 3 to 5 millimeter slices. Okay, those are some of the questions we have. I think we're already at 1 o'clock. I have some other questions listed here, but you let me know. What do you think?
If you want to go on for another 5 minutes, I think we're good. We got a little bit of a 5 minute late start. So yeah, I know we received some questions at registration that we had sent to you. So I think it would be great to take another 5 minutes and cover a couple of those.
Yes. So I think that that's exactly what I was going to do. I'm just looking up. Here you go. So I think there's just a couple questions I have from registration. Let's go ahead and finish those, and then I think we should be good. So how long does it take to bounce back from a craniotomy? In which ways can rehabilitation help? This is a question. After a craniotomy, I say I always use this thing called a rule of twos, and there's variations on this. But again, what I say is most of my patients are in the hospital about 2 days. They are at home or in a rehab center with basically acute care for 2 weeks, and then back to work by about 2 months, and then feeling like their new normal in 2 years. So it's 2, 2, 2, 2. Rehabilitation after brain tumor surgery is key. Everyone's different. Some people hate the hospital setting. Some people will want to be home no matter what. I'm actually one of those. And there are rehab options for home, and there's rehab options for like at a rehab facility. And so after you have surgery, but I think actually before you have surgery, understanding the likelihood of you needing rehab and having a rehab plan is actually really important and should be on your list of questions prior to surgery. Okay, next question. Is it necessary to have brain tumor with all tumor types? Like I said, it's not necessary. There's a lot of different tumor types. I can't go through them all, but the questions you need to ask are basically those two questions. One is this benign or is this malignant? And two is, where's the location of my tumor? That helps guide, I would say, 90% of the decision making. And then actually this other one, we saw it already. We answered the question, so I think we're good. And I think that's the last one, okay? I will say it was an honor and a pleasure to be able to speak to you all, okay? I thank you guys so much. I thank Kathy for setting everything up for us. This is a really, really great forum, and thank you for your guys' questions. I'm so happy, and I really hope that this was helpful and that this really was informative as well.
Well, Dr. Patel, we thank you just for giving so generously of your time and really providing great context, for all of us who are trying to learn more about the brain tumor experience. So thank you so much for your time, for sharing your expertise with us. We really appreciate that.
Of course. Thank you so much.
And then we have one final slide that we'll share. And Jack, you've come up from UCLA as well. Did you have any final thoughts you wanted to share?
No, I think you covered it. It was fantastic. Thank you, Dr. Patel.
Yeah, thank you. And Abby, would you share that final closing slide with all of us? So thank you for joining us today, and along with uh, our speaker and UCLA. We just want to thank you, our attendees, for your attention, for your thoughtful questions, and for participating in today's webinar. If you would like to learn more about Cancer Support Community Los Angeles, visit our website at cancersupportla.org. And then if you have any questions or would like more information about how to get started with a support group, you can email us at info@cancersupportla.org. And you can see a flyer here for a brain tumor specific support group that we have, and would love for you to join us if that is in need that you have. Otherwise, we very much look forward to seeing all of you at an upcoming webinar. Check our calendar and our weekly e-blast. And thank you so much, everyone. And thank you again to Dr. Patel. And we will see you at our next webinar. Take care. Bye.